Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. This week, we will be covering our highlights in skin cancer at ASCO 2026, which we covered live in Chicago. To begin, Alexandra Haugh from the Massachusetts General Hospital Cancer Center discusses real-world safety outcomes with lifileucel adoptive cellular therapy in patients with advanced melanoma.
Yeah, so the main reason that we did this retrospective study was because after TIL got approved in 2024, previously it was limited just to select centers, just done at the NCI, very specific patient population. And after it was approved in 2024 and, translated into a lot of bigger centers that hadn't done a lot of TIL before and into a real-world patient population, we saw that the toxicity burden was pretty distinct in real patients or real-world patients compared to patients who were in clinical trials or treated at the NCI. And what we really found that we struggled with the most was basically how to monitor people when they were discharged from the hospital, because most of the side effects that we know of with TIL, like the cytopenias, the fevers, happen when people are hospitalized and they're in the hospital for about a week or two when they get the treatment and then they're discharged. But we don't really know how to follow them when they leave the hospital or, understanding the burden of toxicity and things that happen when people are discharged. So that was the main kind of impetus behind us doing this project. What we found was that cytopenias persist for a long time after lymphodepleting chemotherapy and people getting lifileucel. And there was a lot of lymphopenia, a lot of anemia, a lot of thrombocytopenia. We found when we looked at CD4 counts over time, over 50% of patients hadn't recovered their CD4 count at 6 months after getting lymphodepleted before TIL. And then concordantly, we saw a lot of infections. So over a quarter of patients that we followed in our retrospective study had some type of infection. I think, interestingly, it wasn't a lot of opportunistic infections, but a lot of garden variety community acquired stuff, just at a higher volume than you would expect in an average cancer patient. And then we looked at things like autoimmune toxicities that can happen with TIL, like uveitis, vitiligo. You didn't really see a lot of it, and it was pretty mild. And then we looked at things like liver function abnormalities, rash. There wasn't a lot of that happened in patients. We looked basically at patients greater than equal to 14 days after cell infusion. There wasn't a lot of organ dysfunction. There wasn't a lot of immune-related toxicity, but we saw a high amount of cytopenias and a lot of infections. And so our conclusion was basically that we're probably using too much chemotherapy to lymphodeplete people before TIL. And maybe if we adjust some of the regimen, it might help with safety of lifileucel.
Next up, Kalijn from the Radboud University Medical Center explores the optimal sequencing of BRAF-MEK inhibition and immunotherapy in patients with BRAF-mutated melanoma and insights from the Cowboy trial.
Don't know the optimal time of BRAF-MEK inhibition prior to switching to immunotherapy. If we look at the previous trials that were done, which are the Secombat and the ABIN trial, they treated patients longer than 6 weeks. It was 8 and 12 weeks with BRAF-MEK inhibition. They showed no differences between the both randomized arm with upfront immunotherapy versus BRAF-MEK induction. They suggested that maybe in patients with a higher tumor load, mainly based on LDH, that might be beneficial to do induction therapy, but in this trial where we only included patients with an elevated LDH, we did not see that difference. It might be that we only treated patients for 6 weeks with BRAF-MEK inhibition and it has been too short to benefit from this strategy. Or it might be that even in patients with a high LDH, there is actually no benefit and it might actually be worse to start with BRAF-MEK inhibition. The Cowboy trial, it's a phase 2 clinical trial in patients with metastatic melanoma with a BRAF mutation with elevated LDH, and we treated them either with induction BRAF-MEK inhibition prior to immunotherapy or upfront immunotherapy, and immunotherapy consisted of full-dose ipi/nivo. Unfortunately, the accrual was prematurely stopped because of slow accrual, but we still included over 70 patients, which we analyzed, and we now have very long follow-up. And patients, if they were in the induction arm, they were treated with 6 weeks of vemurafenib and cobimetinib, or they received upfront immunotherapy. And if we look at the primary endpoint of this trial, which was the response rate at week 18, we see a difference between the arms. The induction group had a response rate of 33%, which was, of course, higher after 6 weeks when they received BRAF-MEK inhibition. And at week 18 in the upfront immunotherapy arm, there was a response rate of 43%. And especially if we look at the survival curves, we see large difference despite the small number of patients. We see a clear benefit for both progression-free survival and overall survival for the upfront immunotherapy arm, where the hazard ratio for the progression-free survival is 0.5, and for overall it's 0.3. So we see large difference between those groups.
She subsequently discusses whether induction BRAF-MEK inhibition can be useful for some patients with melanoma with additional metastases.
BRAF-MEK inhibition might still have a place in patients with melanoma, especially in those patients who cannot start straight away with immunotherapy. For example, patients with symptomatic brain metastases who use dexamethasone, BRAF-MEK inhibition might be enough to reduce the tumor load and get them to stop dexamethasone so we can actually make the switch. And also patients with very rapid disease who are in poor condition, where you do not dare to start ipi-nivo, there's still this option to give BRAF-MEK inhibition, because although we saw worse progression-free survival and overall survival with induction BRAF-MEK inhibition, we still see a response rate of 33% on immunotherapy. So we can definitely create responders on immunotherapy with this treatment.
Following on, Allison Betof from Stanford University provides some background on OBX115, an IL-15 expressing tumor-infiltrating lymphocyte, and the results from the AGNI-01 trial, which evaluated the TIL in patients with advanced non-uveal melanoma progressing on or after immune checkpoint inhibitor therapy.
We know that we take patients' own tumor-infiltrating lymphocytes, expand them ex vivo in the lab, and then give them back to a patient. But that requires the use of high-dose IL-2 to stimulate those cells to proliferate and to do their work. We've been looking for a long time for a way to either minimize the exposure to high-dose IL-2 or actually eliminate it completely, because that's actually the most toxic part of this regimen and actually really limits the number of patients that we can treat with TIL therapy. So OBX115 takes those same TIL cells out of a patient's tumor, inserts a transgene that expresses membrane-bound IL-15 conjugated to a drug regulation domain. At baseline, those cells express that molecule and it degrades at baseline because that's unstable. When we give the patient oral acetazolamide, which is just an FDA-approved diuretic medication, it stabilizes the drug regulation domain, and that then allows the membrane-bound IL-15 to translocate to the membrane. It signals in both cis and trans to activate the same cell as well as nearby NK and CD8 cells and turn them on without giving the patient systemic IL-2. The AGNI-01 study, which was a phase 1/2 trial of OBX115, it included 15 patients treated at the recommended phase 2 dose, which was a dose cap of 100 billion cells. Cells were very successfully manufactured, median dose of 83 billion cells. And in that cohort, we saw an objective response rate of 67% in 15 patients. That included patients that were, 73% of patients who were refractory to IPI plus Nivo, 93% of patients who had progressed on combination checkpoint inhibitor therapy, brain mets, liver mets, mucosal melanoma, acral melanoma. So a really challenging cohort to treat. 67% objective response rate, but also probably more importantly, less toxicity than we see with conventional TIL therapy. So no patients had dose-limiting toxicities, nobody required ICU transfer, and there was no on-study mortality for patients.
Next, we have Omid Hamid from the Angeles Clinic and Research Institute, who comments on the emerging advances in cellular therapies and vaccines in melanoma presented at this year's ASCO.
ASCO 2026 is a cornucopia of stuff for adjuvant and neoadjuvant in melanoma. We look forward to the data being presented by Matt Carlino from the personalized cancer vaccine from Moderna. And they're continuing to show relapse-free survival advantage, distant metastases-free survival advantage, and a hint towards overall survival advantage. This is the phase 2 study of a combination that's already accrued in the phase 3 setting, and we look forward to seeing that. My belief is that vaccine can boost the benefit without increasing toxicity, and that's what this trial showed. Additionally, There are neoadjuvant regimens of triplets of ipilimumab, nivolumab, and relatlimab. So CTLA-4, PD-1, LAG-3 in a neoadjuvant setting in melanoma by Ahmad Tarini from Moffitt. And that's showing a high response rate and even better, a high clinical response rate pathologically. So possibly the ability to increase the benefits you get from neoadjuvant therapy so that you don't need to give further therapy and you can prevent relapse and recurrence. The oral abstracts for melanoma by Allison, Betof from Stanford looks at the TIL therapy, a novel therapy from Obsidian. This OBX therapy is changed in a way to express IL-15, and therefore you don't need IL-2. There are some benefits to having IL-15, but utilizing this TIL, you give a pill that releases IL-15. And so you don't need to do the IL-2 infusions. You don't need the ICU. But what we saw here getting to the bottom of it is a 63% response rate. That's a very high response rate, and a 93% disease control rate. And that is similar to what we saw in the phase 1 study that was done at MD Anderson. What we've also found is a different way to use TIL. Because you can give these pills that release IL-15, and because you have residence memory TIL in your body, you can continue to bolus treatment even when they're out of the hospital. So you can reignite their TIL if you see that they're not having as great of a response as you want, or somewhere down the line, the memory T cells can be reinitiated to bring back response. So I can't wait to see this. I think it is pushing the limits of what we can do for TIL and possibly decreasing toxicities that we see with standard TIL with interleukin-2. And this year at ASCO, there's a different face on TIL therapy. The group at UPMC is going to be presenting TIL therapy for solid tumors where you really wouldn't think that TIL would work. And that's in the developmental immunotherapy session, where they'll show their experience with TILs for patients who have pancreatic cancer, uveal melanoma, and mesothelioma, including other rarer tumors for immunotherapy, and utilizing a signature that they have that they get from a core biopsy. They can identify patients who have a higher chance of responding, take those patients to tumor harvest, and get responses alongst the line of 50%. So this shows what I've always believed, that when you show proof of concept for immunotherapy in melanoma, that's just the starting point to benefit in other solid tumors.
Finally, Peter Forsyth from Moffitt Cancer Center describes preclinical evaluation of intrathecal TRP1 targeted CAR T-cell therapy, melanoma leptomeningeal disease.
We are developing this new therapy for leptomeningeal disease. So let me just tell you what that is for a moment. It's a rare complication of systemic cancer. We all know breast cancer, for example, goes to the lungs or liver or whatever. Sometimes it goes to the brain itself, but in this case, it goes to the covering of the brain, and it's in the spinal fluid. So the tumor cells go up there, they float all around in the brain and spine, and they stick on stuff. And patients are really, really sick. Very, very bad prognosis, maybe 2 or 3 or 4 months at the most. So it's a huge unmet medical need. And then we think it's becoming more common. There's something about the spinal fluid in the brain that tumor cells like. It's like a sanctuary site. They just like to sit there and grow. In any event, we had a couple of approaches to this. One is my colleague, Dr. Jose Guevara, developed this. He built a new CAR T, which is directed against this protein that's expressed on melanoma cells called TRPA1, which doesn't matter. But the CAR T is basically using your own T cells, and then you put on a receptor for your protein of choice, and it's like a homing device. So it's like a smart bomb or something. So in this case, the smart bomb is meant to explode on TRP1. And in mice, we administer this directly into the spinal fluid, and it looks like it cures most of the mice, which is pretty unbelievable. Here's this melanoma line that's really aggressive, B16, that all the mice usually die within 2 weeks at the most. Some of the mice are living for like 2 or 3 months. So it's good to do that, but we're in the business of trying to help patients. Next, I had to determine if this is expressed in people in leptomeningeal disease. So it is expressed on the surface of the melanoma when it goes on the surface of the brain, and it's expressed on the cell surface. So it's not just in the middle of the cell where it's not accessible, it's on the outside where your T cells can get it and attack it and kill it. So it looks pretty promising. We also found that if you're cured using this, then when you try to give mice leptomeningeal disease again, they're kind of resistant to it, which is, I think, good for patients because almost everybody with cancer will go through a lot if they could just, once it's done, it's cured and they're done, right? So that's kind of prevention, and prevention is another thing that we're working on. So it's too early to tell about patients, but we're developing this and going through the production of the CAR T and all that stuff so that we can get it into patients. It'll probably take a couple of years. So it's kind of promising. It's exciting to be at Moffitt and work with people like Dr. Guevara because we work as a team. I'm like a physician scientist of clinical stuff, lab stuff, immunology, bioengineering, mathematics, AI, trying to bring all this disciplines together to focus on new treatments. So it's kind of exciting. I hope it works.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.